Thank you very much, and welcome everyone, and thank you for joining us at this webinar. My name's Professor Rebecca Ivers. I'm Deputy Dean Global Engagement at UNSW Medicine and Health. We're very privileged in order to share knowledge across borders and learn from each other's experiences in health systems management and disease prevention and control, to be working with the National Centre for Disease Control, the NCDC in India, where we're working together on thematic areas of collaboration to strengthen global scientific exchange and cooperation. Together, we're presenting a series of webinars to share information and build networks between Australia and India. I would very much like to acknowledge our distinguished colleagues joining us today from the National Centre for Disease Control in India. We're truly grateful for the opportunity to collaborate in this way. I'd also like to acknowledge that those of us on the UNSW side are meeting on the land of the Bidjigal people, and pay my respect to elders both past and present, and any First Nations people here with us today. Our first webinar was presented earlier in the year by the NCDC by Dr. Himanshu, who was a Joint Director of the National Centre for Disease Control and head of the International Integrated Disease Surveillance Program, an incredibly interesting webinar that really highlighted the incredible capacity of the NCDC in integrated disease surveillance. In this second webinar, researchers from UNSW School of Population Health will present on modelling to inform policy interventions. But before we start, I would like to introduce our very distinguished co-host, Professor Dr. Ranjan Das, who is the Director of the National Centre for Disease Control in the Ministry of Health and Family Welfare for the Government of India. Dr. Das has 33 years in public health education, research and administration, including looking after the entire medical education of the country. He's also a distinguished researcher in community medicine, and he's been at 25 years at India's topmost institutes. He has expertise in pandemic preparedness, international public health, occupational health, maternal and child health statistics and governance, and leadership in nationally funded research programs and collaborations with international agencies. Thank you very much, Professor Ranjan Das. Now handing over to you to say a few words.
Thank you, Professor Rebecca, and my distinguished colleagues from University of New South Wales, Sydney, Australia, and my other colleagues, both physically and who have joined virtually. So this gives me great pleasure to first of all thank Professor Rebecca Ivers, who has also been instrumental, along with Shri Amit Dasgupta ji of UNSW, who have made this collaboration happen. And also to Dr. James Wood, Dr. Alexander Hogan, Mr. David Heslop, Associate Professor, and other colleagues from NCDC and UNSW. It gives me great pleasure to join you today on this important webinar on modeling to inform policy interventions, which is a very, very greatest need of the hour, I would say, moving beyond the things that we have currently. We need to move on to modeling so that we can be able to forecast and predict wherever the outbreaks or wherever the disease incidents are likely to happen. So I extend my warm greetings to you all, and I wish to place on record my appreciation for the collaboration between the National Centre for Disease Control, India, and the University of New South Wales, Australia. Today, we are advancing a shared agenda of using science, evidence, and innovation to strengthen public health decision-making, again, a need of the hour, as we are seeing in this changing health scenario across the country, and also the geopolitical changes, which are also aligning our health priorities simultaneously. I am thankful to the International Coordination Division of the Ministry of Health and Family Welfare and the Public Health Division of this same ministry for facilitating this particular occasion and this opportunity. The past few years have shown us in no uncertain terms that the value of mathematical and computational modeling in public health. Models are not merely technical tools, they are enablers of timely and informed policy making. Our institution, NCDC, And some other institutions within this institution have made a small beginning in this regard, with various small workshops, small level achievements being already achieved. But we will be looking forward to learn from you, learn from your experiences, and work together and share our experiences with yours. And probably they will be very vastfully, we will be benefited from those experiences and opportunities sharing. The COVID-19 pandemic was perhaps the most useful reminder of this reality. Throughout the crisis, models played a crucial role in informing strategies, whether it was decisions around lockdowns, participating health system requirements, or guiding the rollout of vaccination campaigns. So beyond COVID-19, modeling continues to support our preparedness for emerging infections and strategies against anti-molecular resistance and our ability to participate the health impacts of climate change. I believe this opportunity will be a great learning experience for our participants here and the participants that you have there at your end. So I wish this webinar a grand success, and without taking much words and time, I would just hand over to the organizers, your side, and my colleagues over here. Thank you very much for giving your valuable time, each and everyone, and I believe we take the utmost out of this next forthcoming 1 hour. Thank you very much. Namaste and good day.
Namaste. Thank you very much. Really appreciate the partnership. It's such a wonderful opportunity to share learnings across borders, and thank you very much for your time and for your very kind words. I know you're very busy, so we really appreciate this. I'm going to now move to introducing our first speaker, talking on agent-based models in health emergencies, Associate Professor David Heslop. He's an Associate Professor in the School of Population Health. He's a general practitioner, an occupational and environmental physician. He has military responsibilities as Senior Medical Advisor for CBRNE for the Australian Army and to the Australian Defence Force Leadership. Professor Heslop has experience in managing for and management of major disasters, mass casualty and multiple casualty situations. His research interests lie in health and medical systems innovation and research using computational modelling and simulation to address otherwise intractable problems. Over to you, David.
Thanks very much, Rebecca, and thanks very much, everybody, for the kind introductions. What I'm going to quickly talk about today is an area which I work extensively in called agent-based modelling. Some of you on this call may be familiar, so I'd like to run through essentially a broad, big hands understanding of why this is an important emerging and developing area of modelling and simulation. Many areas or many questions in public health cannot essentially occur in areas where empirical data can be quite limited. As you heard from my introduction, I work with military organisations, emergency response and so on. In these areas, there is often a lack of understanding about what the correct policy might be, meaning that sometimes we need to simulate a situation that might be of interest to get a reasonable answer about whether a policy that we're proposing, that could be non-pharmaceutical interventions in a particular population, in a pandemic scenario or many others, might actually be effective or not. The approach is becoming more practical because of increasing compute power, but also frameworks for planning agent-based modelling, which are now becoming more standardised. A common mix that is now also emerging is not only using agent-based modelling alone, but mixing this with other forms of systems level modelling, such as system dynamics and also discrete event modelling. And that becomes a complementary approach known as hybrid modelling. Each of these approaches offers a different lens or a different approach. These answer different questions and can provide information about real-time dynamic systems where complexity is particularly the norm. AI and machine learning approaches and digital twinning concepts that are common in engineering and physical sciences are now also accelerating the field in healthcare, and that's allowing models to be both combined but also run iteratively at large scale. The aim is more realistic simulations of complex systems by leveraging these methodologies. And that allows us to address questions that previously we haven't been able to address, or where collecting information experimentally would be dangerous or unethical, such as in my field, chemical weapons or biological weapons environments, for example. You really can't collect information from a controlled experiment because that would be impossible to do realistically. So then moving along, sort of what is hybrid modelling? So ABMs provide a framework for simulating many interacting entities, and machine learning can be also incorporated into this combined hybrid approach to adapt agent behaviours from data. In addition to that, there are other disciplines which inform this. It's very much grounded, of course, in mathematical disciplines, but fuzzy logic and other decision-making components can be incorporated into this, and that has been extended with machine learning, replacing certain aspects of agent decision-making to become more realistic and grounded in something which is more approximating real-world decision-making and other factors. So if we look at sort of what technologies are out there, agent-based models at their heart actually use similar concepts to historical cellular automata, which is like von Neumann machines. But this has now been extended with computational technologies that are available, and they allow for agent interactions to be the fundamental shaper of these complex dynamics. The diverse system models work together to explore those dynamics. But there's many agent-based modelling systems out there. In my view, there are only a few which really provide the ability to be hybrid systems, and that's what you'll really want to use. A hybrid system allows you to take the best of many different types of or approaches to modelling. There are certain tools such as AnyLogic, which is commercial, but there are open source versions that you can download and use for free, such as Repast, and now Repast HPC, which is for high performance computing systems, and Repast for in Python, if you're interested in using that platform, which I'd recommend. And these allow scaling up to potentially billions or even more sized models, which where you can start to model truly population scale issues. There are other options like Jade, Mason, or NetLogo, which can be discussed at other times. And there's some references that you can use just to have a look at how these models perform and a review of how they are available in epidemic modelling. My preference is AnyLogic for prototyping and Repast for Pi for scaling up. So, as Shakespeare said, all the world's a stage and all the men and women merely players. So what are agents? Well, agents really are self-contained computational entities and can model anything at all. They could be personnel, patients, machines, policies even, and their implementations and operation over time, or even buildings themselves. Defining agents is quite challenging, but these standardised reporting approaches have improved the accessibility and validity of the techniques to the level where the average PhD student could really employ this, or even a master's level student. And that's quite accessible, whereas previously it was hard. Modelling of agents can almost be an art at times, as well as a science. And when we say art, it's about something that's actually going to work. When it comes to a computational perspective, that's becoming less of a problem with higher and higher performance machines. But in the past, careful decisions about how you might include or not include certain components really came down to a bit of a nuance and experience. But fundamentally, understanding statistics, data analytics, and defining mathematical representations correctly of probabilities and outcomes is essential. So some key areas of interest that you can address with agents are like, can human decision-making, things that are coming now as big questions in agent-based modelling are, can human decision-making, including the emergent phenomena of decision-making, be modelled at a lower order? What makes some types of agent representations simple, e.g. myself, like a day in the life of an academic like me, is pretty simple to model actually. But there are other types of more complex agents, such as decision-making agents under uncertainty or in emergency situations. That's far more difficult. And what makes the features of that definable? And that's an open question in the academic world. So the kind of core concepts of complex systems modelling using agent-based modelling are emergence, and these are some examples of emergent phenomena. For example, murmuration or the schooling of fish. These things essentially are phenomena that emerge due to simple rules within systems. Other patterns that can emerge are flocking, oscillation, various gradients and waves, cascading transitions and phase changes, such as this bifurcation graph, which is a mathematical representation of the transition between stability and chaos that can emerge within complex systems. And understanding how these can be observed, even in epidemics, for example, where we transition from between different states or potentially look for different equilibria in our approaches to policy can be identifiable using these kind of complex systems modelling that allow for emergence to be identified. Some examples of the work that we've done using agent-based modelling to answer some policy questions are environmental exposure modelling, which has now become quite complex in our group, looking at things like CBRNE, which is chemical, biological and radiological weapons exposures in combat environments, and there's a sort of diagram here representing something like that, and how individual casualties might perform, and then scaling up to multiple repeated experiments to collect data on this. Similarly, hospital-based simulations can look at optimising clinical policies, but also the approaches to, for example, triage under different conditions, which are difficult to otherwise model using more aggregate or population-level approaches. And the kind of agent sort of detail that can include agents like doctors or agents like patients, and many different types of aspects of those patients influencing care pathways and others. Similarly, in the emergency response world, we see operational risk analytics, looking at, for example, here results or an example of work that was done with Defence here in Australia, looking at sort of multiple zone simultaneous modelling of operations with chemical weapons attack, for example, and this looking at whether the logistics response could be adequate and so on can be analysed using these real-time multiple zone simultaneous real-time models. Equally, if we're interested in optimising policies such as decontamination for large-scale population response, these kind of models allow for incorporation of diversity within the population that's going to be served, which can be quite a difficult thing to predict, but agent-based models allow that to occur. Other examples that we've used for epidemic modelling include using agent-based simulations to generate, for example, contact matrices for unusual contexts that we don't really have information for, like aged care, for example, using a simulated system, and then using those in traditional SEIR modelling. So agent-based modelling can complement existing modelling approaches, and in fact, I would strongly commend using agent-based model as an adjunct to rather than competitor to other forms of modelling. Finally, AI and machine learning really has revolutionised agent-based modelling. We're now able to swap in and out some very sophisticated decision-making components within agents, and that has really accelerated the development of agent-based modelling and is at the cutting edge. So AI-enabled scalable agent-based modelling is really the future. It is limited by the speed of the AI systems as decision-making tools, but we've been working on addressing both bias within those tools, but also how they can be implemented. And finally, the kind of various machine learning tools that can be used can do some pretty amazing things with data to inform ABM parameterization, such as automated codification, generation of synthetic populations, which is a big part of agent-based modelling, and automating certain aspects of data linkage and decision-making, as mentioned. So just to finish up, ABM and hybrid modelling continues to evolve rapidly. Artificial intelligence and machine learning tools are accelerating the move to widespread use of ABM for simulation, and we're seeing this both within the field that I work in policy and emergency response, but also outside of science, where we're seeing this emerging for general widespread population use on demand. And then high-performance compute is now very much standard on your desktop, and this is really turbocharging the accessibility. So small-scale modelling of less than 1 million agents is now highly accessible on a desktop computer with relatively straightforward coding. And future research focus is really going even bigger with more complexity, but also reduced timeframes for modelling and better incorporating the issues of uncertainty, variability and diversity in populations which have previously been difficult to model. Thanks very much.
Thank you very much, David. I mean, it's extraordinary the way things are changing and how rapidly they are. I don't think we would have imagined even 10 years ago that we would be this would be the scenario we'd be working with. So huge opportunities, and of course, increasing use of machine learning and AI is going to transform the modelling platforms that we use in the future. So now we're going to move on to talking about scenario modelling for vaccines, and I'd like to introduce Dr. Alexandra Hogan. She is a mathematical epidemiologist and Scientia Senior Lecturer, again in the School of Population Health. And Dr. Hogan works on mathematical models of infectious disease, focusing on estimating the public health impact of new respiratory virus vaccines. She's working on dynamic models to help inform longer-term planning for ongoing COVID-19, RSV and influenza vaccination programs in Australia. She is co-leading Australia's first scenario modelling hub, and she's a member of the WHO Committee on Vaccine Implementation Research. Over to you, Alexandra.
Thank you very much, Rebecca, and thank you for the invitation to present today. It's a real pleasure to be here. So I'll be talking about scenario modelling for vaccination. So a bit of a timeline, thinking back to early 2020. So back in March, the COVID-19 had been declared a pandemic by WHO, and very rapidly there were many vaccines in preclinical development or in trials worldwide. And by the end of 2020, we had the first trial results emerging, and vaccines were starting to be rolled out and implemented globally. By mid to late 2021, things had shifted quite a lot, and we had booster doses then being rolled out globally. So as we know, and as was reflected on by Dr. Daz earlier, mathematical models were quite critical tools during the pandemic. So they were used for forecasting, prediction and short-term decision-making, but also for longer-term strategic health policy planning, including for vaccination. So just focusing on this sort of part of this timeline here was in this time period where we had vaccines being trialled, but we wanted to know when those vaccines became available, how would we use them? And mathematical modelling is very well posed to help answer some of these questions. So we could use it to explore questions such as once a vaccine product is approved and doses are available, who should be vaccinated? Within a country, who should receive doses first? So whether that's older adults, those at risk of severe disease, the working age population who do a lot of transmitting, or healthcare workers or other priority groups. And how do preferred strategies change if the dose supply is limited? And ideally, how should doses be distributed globally? So these were some of the questions that arose early in 2020, and models were used to answer these questions in very different ways. And so I'm just going to touch on this second question here for this presentation around within a country, who should receive doses first. So to present the model that we used at the time to explore some of these questions, and similar models were used by different groups globally who were exploring all these sorts of research questions as well. So this is an SIR model, as David just mentioned in his talk. So broadly, we stratify the population into different disease states. So we can categorise the population as either being susceptible in green, exposed, in an infected case, whether that's asymptomatic or a mild case, or a more severe case that results in an ICU or hospital admission. We can track deaths, and we can also track recovery and then waning immunity, so people becoming susceptible again. Using this structure, we can then use systems of equations to model how people move between those states over time. These models can include many complexities. Some of these are things like age-dependent patterns of disease severity, so older people are more likely to have severe disease, country-specific patterns of mixing between age groups, so contact matrices, and then also individual-level immunity dynamics. So using this model structure, we can then implement that to simulate health impact over time of COVID and explore different strategies. So in this instance, this model was used to simulate different age-based rollout strategies as part of a piece of work that was being done to inform WHO guidance. So on this plot on the right-hand side, days is simulated, so time on the x-axis, and then the y-axis represents the health impact, which is here, this is deaths per million per day. The dashed line represents the counterfactual scenario against which we would measure impact, and then these different coloured lines show that the deaths we would see in these different scenarios for age targeting of the vaccination. So where light blue is if we're just targeting the vaccine to, say, 50 years and older, and then the red line is targeting the entire population, including children, and the other two sort of sit in between. So we can use this to simulate these different strategies. Using this modelling framework, we can also do that for different global settings. So here I've illustrated results for one high-income country setting, but you can implement different contact patterns and demographies to implement other countries as well. And also use this to vary different vaccine characteristics. So we'd say, what if efficacy was 50% versus 80%, and see how the outputs changed. So when we have these simulations over time, what do we then do with them? So we can aggregate that modelled impact over time and then explore the total impact of these different strategies. On the right-hand side, you'll see these deaths averted per 100 fully vaccinated people. And what we can see here is that the largest impact is if older adults were vaccinated first. So we get the most efficiency out of our vaccines with that older person strategy. But over on the left-hand side, you can see that even by adding additional groups in, we can always see an additional benefit of vaccination. What this finding was it was consistent across different vaccine assumptions, so efficacy and mode of action, so whether vaccines were protective against acquisition of infection or also severe disease and death, and across different settings. And really importantly, and this is where this sort of policy impact comes into play, is that this was demonstrated by different models and expert groups around the world. So a number of different modelling groups looked at these questions using their own modelling frameworks and their own assumptions and methods. And broadly, I would say all of the different groups that looked at these questions really found the same thing around the efficiency of different age targeting strategies and the impact of vaccination. In terms of how this translated to policy, this was collaborative work with the World Health Organization and different regional WHO offices, and other groups, as I mentioned, also contributed to this work, including groups in Australia. This all collectively formed part of the evidence base for global health policy guidance on COVID-19 vaccination, including these two strategy documents that I've flagged here. And these were published initially earlier on in 2020, but then they were subsequently updated over time as the landscape changed and priorities changed. So back to the timeline and thinking about how things evolved over time. So models really evolved over time as the pandemic progressed. So they generally increased in complexity, more data became available, and also our understanding of disease epidemiology changed. We also had booster doses being implemented and waning immunity over time, which sort of complicated things. But most importantly, the question changed. So really, instead of thinking about emergency rollout of vaccination, now that the focus is very much not on preventing infection, but preventing, hospitalisation and death, what is the value of ongoing COVID-19 vaccines? And again, this is something that models can be used to look at. So they can answer questions such as, what is the benefit of continuing to vaccinate with a yearly booster? What is the benefit of updating the vaccine product? And how many lives will vaccination save if we see a new variant? And the recommendations around COVID vaccination has changed as well. So currently in Australia, it's recommended over 65 years, every 12 months, with an additional dose for 75 plus years. And in terms of what our vaccine uptake looks like at the moment, it's around 50% in the last 12 months for people 75 years and over, and around a quarter of adults 65 years and over, 65 to 74 have been vaccinated in the last 12 months. So looking at endemic COVID-19, so we can use this very similar modelling structure to look at the impact of these annual peaks of COVID-19 in a more endemic fashion. So when the virus is well established in the population, and the impact of vaccination on top of this. And you can see on the right-hand side, looking at these different vaccine product strategies, the impact of a vaccine against hospitalisations with sort of moderate uptake is around 10 to 15% of hospitalisations averted. We can also look at how impact might change with a novel variant strain. We looked at the timing of vaccination relative to a new variant emerging, but what was most important was the relative, the degree of matching of a vaccine to a novel variant strain that had the most impact. And we can see that if a vaccine is well matched, the impact against hospitalisations, if a new variant emerges, can be much more substantial. So the order here of sort of 20 to 25%. So in terms of how we value a vaccine becomes much more valuable in the context of this novel variant strain emerging, but those events are very difficult to predict. So just to finish here, modelling is a key tool to inform vaccine policy, not only in a pandemic or epidemic emergency situation, but then thinking about longer-term use of established vaccines. I think a key learning from all of this work was that for models to be useful, they must be adapted as the landscape changes and these policy questions change over time. Thank you very much, and I will pass to the next speaker.
Thank you very much, Alexandra. That's incredibly informative. And I mean, I think, it just speaks to how important your work is, because it makes a huge difference as vaccination is rolled out. Our final speaker today is Professor James Wood. Professor Wood is head of school, the UNSW School of Population Health. He trained as an applied mathematician, and he has research interests across a broad range from evolutionary and immunological processes to cost-effectiveness evaluations for disease interventions. He's worked extensively with state and federal governments on models to underpin the COVID-19 responses in Australia. His primary application area is respiratory viruses and vaccine-preventable diseases, but he also has interest in tuberculosis and sexually transmitted diseases. James is talking to us today about integration of modelling with infectious disease surveillance. Over to you, James. You are muted, James.
Regardless, the webinar is always one. Thanks for your attention. So I thought I would take us on a slightly different direction, talk about one of the main changes during the pandemic, which was the sort of rise of modelling for epidemic intelligence. So if I reflect back to when I started in this field, which was 20 years ago, really the primary focus of modelling studies was on these sort of longer term results, so things like the potential effect of a new vaccine. However, even at that time, there was some use of models in sort of infectious disease emergencies, and ones which come to mind are things like the foot and mouth disease outbreak in the UK in 2001, and obviously the SARS regional epidemic in 2003. And sort of in the subsequent kind of decade, there was a development of sort of methods to start estimating kind of key parameters associated with epidemics in near real time. So particularly these papers by Wallinger and Tunis, and go to the next decade up to sort of Anne Corey's work in 2013. And these were sort of able to fairly quickly tell you what transmission looked like at this time, and whether you're on a pathway to rapid growth in cases or maybe decline phases that might influence results. But at that time, it was largely theoretical. And so one of the reasons we really want to know about the reproduction number is it determines whether you're in an exponential growth phase or a decline phase. And, critical work early in the COVID pandemic, which I'm sort of displaying here from Wuhan in late January 2020, sort of shows you the pieces that you need to do this. So you need basically an epidemic curve, as I've got it left here, but you also need information from case surveillance about how rapidly infection is spreading from one person to another, so infector or infectee kind of pairs. And that paired information told us that the reproduction number for SARS-CoV-2 was above 2 and a real problem by February 2020. So that sort of set the scene for the global pandemic. But that's still really scenario modelling and not what I would call sort of forecasting or information for epidemic intelligence. So that's really started to build after that work. And so by about April 2020, we started to see these development of these tools. I'm showing graphs here from a tool called EpiNow2, which is one we used early on in Australia during the pandemic, developed by researchers at the London School. And this gives you an example of what this was able to sort of show basically in near real time, as long as the data was arriving with you rapidly. So you could kind of get a sense of when infections were occurring, what the trajectory of the reproduction number looked like over time. And it could also be quickly run across a sort of a variety of areas. For example, if you wanted to look across the United States at what growth looked like in different states, the tool was well adapted to doing this. So we started to have these tools being available even quite early in the pandemic. In the context of Australia, we faced a couple of different problems. So we'd actually done very well with our pandemic control because of our country isolation, our sort of ability to implement very strict restrictions. And so we spent a lot of the first 18 months of the pandemic with almost no cases. And in fact, some states had no cases until mid-2022. And so one of our questions was, what are the potential for epidemics when we have no cases? And so our approach there was to work on the basis of surrogate data. And what I mean by surrogate data was, for example, there was app data available from Google and Apple at the time about how people were moving around and changing their behaviour. But we also had kind of commissioned behavioural surveys that occurred weekly, talking about how people behaved in terms of the number of contacts they were making per day, but also what sort of precautionary behaviours they were applying and how consistent this was. And so we had time series of these sort of information that we could feed into our models. The other sort of piece of information that was very useful at that time was some information about how long it was taking us to sort of identify cases, to give us a sense of how well contact tracing and so on was working. And so at the right here, I've kind of shown, this is roughly what our sort of local cases look like in Victoria in 2020. We had one sizable outbreak, but most of the time we had very few cases. And so when we had all the information, we had this sort of information about the reproduction number. But even without cases at all, we had this sort of time series of what transmission looked like. And the important thing here is the dotted line says, if you're above the dotted line, you're at risk of epidemics occurring if cases come in. And we had that sort of information to help guide government. And this was sort of put into reports that were circulated to important disease committees sort of on a weekly basis throughout 2020 to 2023. I wanted to make a kind of a quick distinction between forecasting and scenarios because they do sort of overlap in the sense that you sort of run the things at the same time, but they have slightly different purposes. For forecast, we're really thinking about data-driven elements which are on a quite short time horizon, sort of 1 to 4 weeks ahead, and very much determined by the data we've had over the recent period. Whereas scenarios, we might be interested in sort of short-term scenario projections for a bigger change. For example, I've got in graphs here from the UK response where they were looking at how quickly do we relax our restrictions as our vaccination rollout proceeds, and giving a sense to policymakers of what the consequences might be for this under some different assumptions and across different models. Okay, so that's usually for a more major decision, whereas the forecast might be feeding directly into what are health departments doing in terms of next week, for instance. So just to give a little bit more on forecasting itself, I think it's a very familiar idea from the weather in terms of the kinds of time frame and outlook, and a little bit similar to the weather. We can't go very far out into the future without having a lot of uncertainty, particularly with a rapidly transmitted infection like flu or COVID. So the general approach is to fit a model to retrospective data and then to project cases forward for, sort of 1 to 4 weeks. And some of the innovations, I guess, across the pandemic were including things like ensembling. So you have multiple groups submitting your models and you sort of put these together a little bit like a meta-analysis, and you get slightly better predictions as opposed to that. However, we still ran into times where these forecasts, even in that period of time, were not accurate. And so I picked a particular period here, which was in late 2021, where all our projections were essentially saying cases should be stable, but they did not remain stable. And so something that happened at that time was the emergence of a really important new SARS-CoV-2 variant, the Omicron variant. And so in practice, the forecast over this period of time for New South Wales was wrong. And in fact, we saw very, very rapid case growth because we'd missed this important kind of element of the virus that wasn't included in our forecast sort of models. So one of the things I've been interested in the sort of the period since then is integration of that sort of whole genome sequencing type data that you can collect from clinical samples. And I might just skip ahead to that because we're running a little bit behind time. So in New South Wales, for example, we on a weekly basis sort of produce these sort of graphs of the proportion of our SARS-CoV-2 identified samples that are due to different lineages. And one of the things you see is that these often emerge sort of rapidly and become a large proportion quite quickly. And so this sort of proportion information over time can tell us when we've got another rapidly growing one, which might lead to a new wave occurring soon. So earlier this year, there was what was referred to as the Nimbus variant, which popped up in Australia in about April. And this led to us revising our predictions, for example, of the next wave from probably something like August back to sort of June, July. And I put up sort of predictions we generated in late May here. I think in the end, we ended up somewhere around this yellow line and fairly accurate sort of timing for this. So this is sort of information we feed directly back to our state health partners, and it can help them make decisions about whether they might do something like pause elective surgery, for instance. So I guess in terms of where are we going, there's obviously lots of developments with surveillance. I think some of the exciting ones include wastewater, although we're still trying to tease out some of the issues with interpreting wastewater data quantitatively. But another one which I've been sort of working on with colleagues here is doing sort of surveillance of immunity, because that's the other part of the picture with respiratory transmitted infections. There is immunity that affects what happens. And so can we sort of use things like pooled sera from blood donors to tell us about immunity to different variants and start to incorporate that into predictive models? So that's an area of active interest for me. I think just to kind of wrap up, some key takeaways. So I think really nowcasting and forecasting and sort of, integration into sort of data streams for public health and health authorities became mainstream during the COVID-19 pandemic. We've integrated into our business as usual approach for major respiratory viruses here in Australia. And, we're really looking at the potential to integrate new surveillance methodologies, but also to think about how do you apply this sort of to other important infections, maybe outside of this respiratory space. Just like to acknowledge collaborators in the ACIFA, modelling and forecasting collaboration in Australia, and my jurisdictional health departments in New South Wales, Queensland, and the ACT. Thanks for your attention, everyone.
Wow, thanks very much, James. Just a phenomenal amount of work and just so important. And I think, we many of us know what a critical role you played in modelling and working with state and federal governments during the pandemic. So, incredibly important work. Now, we do have time for some questions. So I'm going to come back and ask a few questions. David, I know you've answered this in the chat, but I'd like to just ask for the benefit of people online. What methods are you using to acquire high-quality data for agent-based modelling?
Yeah, that's a great question. Thanks, everyone. essentially, you need to have some form of empirical data if you're answering questions about something which occurs commonly. So there's really no excuse to create an ABM without empirical data when you've got the opportunity to collect it, is my first message about any prospective modelers out there. We have large-scale data now available through our state health system. We have a number of systems which are used routinely for collection of data with patients. That includes flow data through our hospitals and so on. So for clinical modelling, we do have access to quite high-level, sort of highly detailed data, but even still, at an individual level, that's often incomplete and not sufficient. It depends on when people enter data into a patient's pathway through a system, so that can be quite delayed depending on what's going on in the hospital. For other types of modelling where it's less commonly or rarely seen, the thing that you're trying to develop policy for, often you'll need subject matter experts who've got clinical experience, and sometimes you're just going to have to make the best estimate based on policy, but also on the anticipated clinical approach. Another aspect of collecting data which is important is the issue of decision making. This, as I said, is a new area. So, it's a bit of a gap in the research, and a lot of computing science work is looking at this as how to model decision making. The data for that is generally large data sets available online from various sources such as Kaggle and Google and other places which indicate how people are making sort of decisions on a minute-by-minute basis across a day. So those kind of big data sets are also important for understanding what people do over time for real. Yep.
Right. And what about what data is used for agent-based modelling for, say, CBRNE events like a chemical spill? How do you get data for that?
Yeah, so the actual physical chemical data is well known. So there were large aspects of the model, like the environmental aspects of the model, which are all physical science data, where there's whole databases of that. So, but the human aspect to that is quite challenging. We do have observational and time and motion data from exercises and drills, where we know sort of what people, once they're immersed within those situations, tend to do. We also have opinions on what people will do. They may not be accurate, but that's the best that we have sometimes. So you incorporate that using various mathematical representations of what people are doing, sometimes fuzzy logic, sometimes a machine learning model, and you can train up machine learning models to represent those decision-making processes if you need.
Okay, way beyond my level of understanding, but it sounds good. I'm going to come over to you now, Alexandra. Just thinking, I mean, clearly, given what you've told us about COVID-19 modelling and how it's evolved since the start of the pandemic, and it's really changed quite a lot. What do you see as the future priority questions?
I think it's probably around, like, these questions are going to be really country specific, and they would depend on what the existing immunisation program looks like and how countries want to balance, respiratory virus vaccination against other immunisation priorities. So I think those are the questions is, we have new vaccines on the market now, say for RSV. What's the best way to use limited health resources? So how should these vaccines play a role in that? It's probably the main question going forward, I think.
And clearly partnerships have been really important to your research. Can you talk a little bit about that, about how, how that's driven your work?
Yeah, I think for some of the work that I talked about today, that has very much been driven by the policy questions at the time. So it was a very policy-motivated research exercise because of the needs of what was happening during the pandemic. So some of this work came about because, World Health Organization had put out a call for modelling evidence to inform these policy decisions that they wanted to make. So that was where those questions came from. But then in practice, as that research evolved, it involved a lot of back and forth between the policymakers and, say, WHO and other modelling groups and other counterparts that informed how it progressed over time. It wasn't sort of done in isolation at all. It was a large collaborative exercise.
Absolutely, a large, successful collaborative exercise. And I think we saw that. I know many of you were all working very closely with WHO and sharing information very, very freely.
Yeah, I think so. And I think James would would find the same thing with, work that was going on in terms of the surveillance and the Australian response, is that it was highly collaborative.
Yep. So, James, coming to you now, how did the sort of near real-time forecast influence the responses by health partners in the pandemic?
Yeah, it's a good question. So I think a couple of examples I'll give. So one was, even during the sort of the Delta wave in Australia, we managed to contain cases but not stop transmission. So we had this slowly growing wave here. And one of the things we were able to do is sort of inform things like our sort of testing strategy and our approach to contact tracing, because we became aware, for instance, that delays between sort of a person presenting a sample and them actually being sort of traced, because there were, the testing capacity was being saturated, as was our contact tracing saturated. So we were able to sort of advise on changes to that. Another one was during the Omicron wave. So, for example, we sort of quite quickly went from being able to work with just case forecasts to forecasting hospitalisation. And we sort of did this by essentially working quickly with health providers to have access to a sort of a hospital linkage data set that linked basically the cases to hospitalisation, so we could predict what we were going to see in terms of hospitalisation. That was quite important for them, because everyone was very worried that ICU we would run out of beds and so on in that period of time. And it was an awkward time of year because it was like Christmas. So a lot of people were on leave as well. So we were able to fairly quickly give them the general trajectory that things were on, and that we were below a level that was going to be a real. So that was probably the most useful single element, I would say, during the pandemic, where we kept giving that sort of information, particularly over the next year as we had multiple waves. So that I would say that's the key kind of one.
And do you think, what's the potential for this to be applied more widely in disease control, like for vector-borne disease going forward?
So I think the general methods apply to across infectious diseases. There are obviously differences. So, I mean, if you've got a vector-borne disease, you've got the role of the virus or whatever pathogen it is within the mosquito or the other organism, as well as the humans. And so you have those challenges around the vector surveillance as well, and how do you draw in that information. But otherwise, the same sort of techniques for forecasting should be able to be applied. And I don't see reasons why this can't be used within sort of, seasonal epidemics, for example, for whether it's for dengue or chikungunya or other sorts of infections, to look at what might be happening in terms of peak timing and so on.
Now, I've got a really good question from the NCDC in India for you, James. Has aircraft waste surveillance-based models been used in Australia for COVID-19 or any other disease?
Aircraft waste,
Yeah, aircraft. Is that something that anyone's done? Used aircraft waste surveillance?
So this in particular, so I guess there's been some wastewater studies done at airports. I think it's an interesting one, right? So I think when you're thinking about if you've got a new pandemic or something like that, particularly, and you're interested in whether there's anyone on the aircraft who might be infectious, you're worried about symptoms, you might consider doing that sort of testing. The only thing I'd say about that, our experience with wastewater surveillance in Australia during the sort of elimination period, which was done at fairly local levels but not on sort of aircraft, was that we tended to get a signal about the time we got a signal from the case system as well, so that it was sort of more when people became symptomatic. So I'm not sure how good it is at picking up people who are pre-symptomatic, but that I certainly think it has potential, and doing surveillance at airports could be quite an efficient way if you have a major sort of hub, for instance.
Great. Now, just to wrap up, we've got a couple of minutes. I'm going to ask each of you to answer this last question, which again comes from NCDC. It's well known that all the models have inherent limitations. With that background, can you shed some light on how you best communicate the best use of the models to policymakers? How do you do that? So we might actually start with you, James, and then go to Alexandra and then David.
So I generally like to present models to policymakers along with other evidence. So I like to talk about some of the epidemiological evidence and some of the other data sources together, because I see them as part of a package of information, particularly in this sort of situational assessment. You've got various data streams and they won't always align, and sometimes your models are wrong, right? And some of the data is correct. So I like to be able to present those things together. But I also think it's really important to have regular meetings with your sort of policy side. So we really found when we were meeting weekly with our policy partners, that was best, because you start speaking the same language a bit more, and they know better questions to ask, and you know how to, I guess, shape your findings. So that's in the situational assessment phase. I might pass to Alexandra and David to talk more about longer term questions.
Alexandra.
Sure. One way that I would do this is something I touched on, is that models will often need to be adapted to answer that particular policy question that's been asked. So very rarely you will find that you've got this model that's ready to go that's exactly suited something that someone's asked. And even for the same pathogen, you might need to change things or adapt it in a certain way to look at something from a different angle. So I think the way that I would do this is be very careful in explaining why this model framework is suitable for looking at this particular question, but maybe can't answer these other things that you'd be interested in. You may need some other approach to look at those.
And David, for the last word.
Yes, so for me, it's always been a question of building trust. And part of that building trust is an explainability of the model. In agent-based modelling, there's always a question of validity. And validity is interesting because often it's, and I'd say the gold standard, of course, is grounding it in empirical data. But often a validity can be established through a strong narrative. So it's not establishing that trust, in my view, requires a simplified explanation of, generally a written explanation of the modelling outputs and why they're impactful, but you need to have a fairly lengthy technical description to back it up, and that's something that just needs to be there for reference. So my experience that to communicate, you generally have a short précis which has got the so what's, and then you need to have the backup data to build that trust, and without that, then it's easily shot down. So it's balancing what you put into that summary, which is the key thing. It's often you have to tailor it to the particular audience. In my experience, if it's a defence audience, that's a very different audience to a Department of Health audience. They want to hear different things, and they want a certain degree of so what, that you're willing to digest the information for them, and that will go a long way to building that trust.
Thank you very much. Well, we are out of time. Thank you very much to all of our speakers. I think we've heard a lot about modelling, but also about the really important aspects of actually translating the work into policy and practice, and partnerships and trust are sort of at the foremost of that. Thank you very much. And thank you very much to our collaborators and colleagues at the NCDC in India. It's wonderful to see so many of you here. Thank you for so generously sharing your time with us. And thank you to all of our audience members. We will be circulating the presentation to anyone that's registered. So thank you everyone for joining us, and we look forward to seeing you again for our next joint webinar. Thank you very much, everyone.